Hi, I'm Gene Hern. I'm an EMS medical director. Today, we're going to walk you through some really important training for EMTs on how to combat the opioid crisis and how to help your patients who might have a substance use disorder. As an emergency physician, we have some special tools and training, but there's a lot of really important things that you as EMTs could also do to help your patients. So today we're going to hear from two other people, including myself. The first person you're going to hear is Alicia Gonzalez, and she is the clinical training director and one of the implementation leads for EMS Bridge. We're also going to hear from Vanessa Lara. She's the EMS Bridge project manager. And together we're going to guide you through material that's designed to support EMS teams in this implementation of some important interventions for patients with an opiate use disorder, some of which might include a medicine called buprenorphine, which you may have heard about, but others include taking patients to a facility which might treat them the best. I also want to say that this program is sponsored by EMS Bridge. We bridge emergency care and community health, and also through the Public Health Institute. CareStar Foundation has also helped with our training and implementation. So today we're going to talk a little bit about the opioid use disorder and treatment. We're going to talk about what might be some roles for EMTs. We're going to talk about how to engage patients and use something called motivational interviewing to help them. And then we're going to bring it all together with some case studies at the end. So to start out with, we're going to hear from Alicia Gonzalez. Dr. Gonzalez is the clinical training director and one of the implementation leaders for Bridge. She's going to talk about the opioid use disorder problem, as well as sort of the opioid crisis and potential treatments available.
Hi, I'm Alicia Gonzalez. I'm an emergency medicine doctor here in California and the clinical training director for the California Bridge program. And it's my privilege to be able to talk to you today a little bit about the history of the opioid epidemic, how we got here, but way more importantly, the basics of medication for addiction treatment, or treating patients who suffer from addiction with medication to help save their lives and help them live well. It's one of my favorite topics to talk about. So hopefully that comes through and we all learn something together in the process. Before we get started, I want to make sure that we level set just for a second so that when we say opioid, we're all talking about the same thing. Opioid is the correct term for the larger family of drugs and medications that all essentially stem back from this plant, opium. Opium-related products, whether synthetic or natural, cause euphoria, they cause sleepiness, they take away people's pain, they make you feel super relaxed, and they make people generally feel high. However, at higher doses, they can cause respiratory depression or even respiratory arrest, also known as overdose, which leads to death. How did our country end up in a place where there's truly an opioid epidemic with how many people are dying from opioid use disorder? And the answer is, it's complicated and multifactorial, and there are a lot of things that played in, but there are a couple of big ones. And one of them is that back in the 1980s, Big Pharma started putting out some papers saying that opioids were totally safe and effective, and that no one should ever have to be in pain, and we should be using these medications, quote, freely and without concern, and that, quote, they're not hypnotic, and there is no danger in acquiring a habit. I mean, really overselling the safety profile of these medications. And then at the same time, the VA and the Joint Commission, previously known as JCO, and then patient satisfaction surveys, all started pushing for this, like, pain is the fifth vital sign, must treat pain, must address pain, must get pain down as one of the biggest drivers in medicine. And so we saw a huge surge in using and writing prescriptions for opioids in the medical setting. In parallel, around the same time in the 90s, the Mexican cartels started really pushing heroin into the United States. And so black tar heroin made its way across the country, and now we had a huge amount of access to illicit heroin and opioid in our communities as well. In more recent years, we had things like the COVID-19 pandemic and general rising costs of life and all kinds of stuff, leading to both limited access to healthcare, specifically chronic pain management and mental and behavioral health services, as well as things like unstable housing, tons of skyrocketing rates of depression and anxiety ever since COVID. I mean, the world is in a really rough place and there's a lot going on for people. And so, in the midst of all these economic and emotional concerns, people are driven to find other ways to cope and to deal with their circumstances. You put that all together in one giant bundle, and you end up with the US opioid epidemic, which unfortunately has led to an incredible number of lives lost. This is a graph that you probably have seen before, and unfortunately just really makes visually obvious the rapid rate of rise, the number of people who have started to die from opioids comparing 1999 up to 2021. In fact, in 2021, over 100,000 people died from drug-related overdose, and of those 100,000 people, 80,000 of them were from opioids. So if you look at that in a different way, this is again showing you all drug overdose deaths. And you can see that the vast majority are from opioids. That's the black line at the top. And of those opioids, I mean, gosh, almost what is that? 5/6 of them are from synthetic fentanyl. Fentanyl is now all throughout our communities. It's found clandestine in most other drugs as well. And it's a really potent, and it's definitely just increased the number of people that have unintentionally died from opioids. Said a different way, just to kind of give context to how many deaths we're talking about, in 2021, the number of people that died from opioid overdoses in that year was more than the number that died from car accidents and gun violence combined. That's an alarming number of people to die, and certainly not the kind of record that we're trying to be setting here. And as mentioned, we know that we in medicine were part of starting this problem and pushing opioids as our primary way to treat pain. And so thankfully, there's been a lot of work done to decrease those prescriptions, to work on using alternatives to opioids or Alto in the treatment of pain. And that's really great. I mean, our work in prevention is certainly not done. But unfortunately, as this graph shows you, despite a significant reduction nationally in the number of prescriptions, so the shrinking little purple graph at the bottom, despite those efforts, the number of deaths continues to rise. That's the blue bar growing on the top half of this shelf. And the reason why is because illicit fentanyl has led to a massive increase in fatal overdoses. And we cannot stop that by curbing our prescription writing. While it's obviously a really sad and a bleak picture, the good news is that there is a light, and the light is named MAT, or medication for addiction treatment. You may have heard it as medication assisted treatment. That was its previous term. But MAT is critical in treating patients who have opioid use disorder specifically. And to be able to do that, we first have to acknowledge what science has overwhelmingly already showed us, which is that substance use disorder, addiction, is a medical neurocognitive problem. When we use opioids, it triggers a huge dopamine surge in our body, and that is what our body gets addicted to. Drugs cause a very powerful feedback loop, and it just drives us to do the same thing again and again and again. But it doesn't mean these are like bad people, are not worthy of care, that they're doing this like quote on purpose or deserve any of the negative consequences that are happening to them. People choose to cope in all kinds of different ways. I mean, compare this to like unprotected sex or risky sex, or eating fatty foods or not getting enough exercise. If you do that, you can end up with obesity and diabetes. But we don't withhold insulin from you because you made poor dietary choices. We give you the medications to help treat these consequences of your choices, but now chronic disease. In addiction, it's the same. Not bad people, unfortunate choices with lasting severe consequences that thankfully do have treatment options. And that is the key here. Why do we need medication anyway? Well, remember that some drugs, as you use them over time, you can build a tolerance, right? So if you take an opioid pill every single day, over time, that same pill will not give you the same effects that it used to unless you take extra. Once you develop enough tolerance, your body starts to become dependent, meaning that when you don't have opioid in your body, you can't feel normal. You go through withdrawal, which is horrific and painful and terrible, and would absolutely drive any rational person towards seeking out opioids again to stop that pain and to stop that process. So MAT honors that for a person who has opioid use disorder to feel normal, for their brain to feel stabilized and be able to function, they need to have a little bit of opioid replacement in their system. Not only does MAT make people feel better, though, we know evidence shows it does save lives. If the general population's risk of death over 5 years is, let's call it 1, we know that patients who are using opioids not in treatment have a 6 times higher risk of death than the average person. But if you get that person on MAT, their risk of death comes down to less than 2 times the general population. That's a giant reduction in mortality, one of the most impressive mortality reductions of any medicine that we have. But it tells you that number one, OUD, opioid use disorder, has a really high mortality risk. But number two, the treatment, MAT, has an incredible ability to save lives and reduce mortality. Why is this an acute care problem for like a paramedic or an ER doctor or a hospital? Like, why are we worried about this? Because when they looked, this is a study from the East Coast, when they looked at patients who had just overdosed on naloxone, or excuse me, had just overdosed on opioid and been resuscitated by naloxone, either pre-hospital or in the hospital, that the risk of death of that population was really high over the next year. And that makes sense to me, right? Like that person just died and we gave them naloxone and they lived. And so it makes sense to me that they would be medically really vulnerable. But what we know is that of the people who die in that year, 20% of them are going to die in the first month. And of that group, 20% die on the first 24 to 48 hours. So that big blue spike you see in this graph is showing you that the highest rate, the highest risk of death is in the next 1 to 2 days after that overdose. So every time that we resuscitate a person with naloxone, that person is incredibly medically vulnerable, and we have an opportunity to intervene and save that life. And while we know those moments are so critical, historically, there have been way too many silly barriers preventing us from doing this work. And so part of making a medication first strategy work is making it a easy to access low barrier entry. For example, we do not exclude patients who are using other drugs. You use opioids and meth and alcohol, whatever. I'm still going to treat the opioid use disorder part of it with MAT. We don't require long intake questionnaires or routine urine toxicology screenings. Those things might have a place in ongoing care to help, providers in the outpatient setting monitor compliance with treatment plans and blah, 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 but certainly not to access care, right? We're just going to start the medicine, save the life, stabilize the brain. We don't mandate things like participation in NA or group therapy. While those things have been shown to help certain patients, they don't always help everybody. And it shouldn't be a precursor to keep you from being able to get the care that you deserve if you don't do those things. We also don't demand people going cold turkey, right? Start the medicine. Just start the medicine, save the life. This is similar to me, like if you have a diabetic and their new diabetes and their blood sugar is really high. Can you imagine if their doctor said, yeah, so here's what we're going to do. Your sugar's like 500, but you know what? For 6 months, I want you to diet and exercise. You're going to go to this like group teaching clinic where they do how to make healthy foods class, keep a food diary. And like at 6 months, if you're doing a good job, then you can have insulin. Are you serious? No, don't do that because the insulin is critical and saves a life. Same here. Buprenorphine, MAT, whatever, it saves lives. So we got to get our patients on medication and take those barriers away. The goal, again, is a low barrier medication first treatment. MAT reduces cravings, it stops withdrawals, it prevents overdose, but it does not matter how good our treatment is if it's not in anybody's body. We want to get it into our patients, rapid, same day, low barrier, get those people on medication and increase the number of lives that we're able to save in the process. When we say MAT, we're generally talking about 3 different medicines, more so the agonist side of things. So on the left-hand side, you can see methadone. Methadone is a full agonist opioid, maybe the more common one that you're used to hearing about. It has to come from an OTP or an opioid treatment provider. People have to go to a quote methadone clinic every day, but it's a really good medicine. It does work. It is evidence-based. Naltrexone is an antagonist. It's a deterrent-based medication. If you have it in your system, the idea is that the opioid that you take wouldn't work. And then buprenorphine in the middle, we're going to spend a lot more time talking about for some practical reasons. But before we move forward, I want to emphasize that is not to knock the other meds on this screen, especially methadone. Methadone is a good medicine. It saves lives. It is evidence-based. And if a patient is doing great on methadone, we want to leave them on methadone, okay? But for some practical purposes, buprenorphine is a really good choice, maybe the better choice for a lot of us in acute care. Buprenorphine comes as an oral dissolvable tablet or film. There are also some injectable versions, but generally we're talking about the oral version. You have to let it dissolve fully in the mouth. It does not work the same if you swallow it. So help them get a little water, wet that mouth, get the medicine in, let it dissolve. no food or drink for like 15 minutes to get that medicine all the way absorbed. It does not have the same bioavailability in the stomach. It can come as plain buprenorphine or combination bup naloxone. A common brand name for that one is called Suboxone. I don't say that for any financial reason, but our patients actually call it Suboxone a lot. So I want to make sure you know that term. So they'll call it buprenorphine or bup or boop or Suboxone or Boxin. They call it all kinds of stuff. But we're really talking about buprenorphine as a family. The idea behind the combination tablet is that the naloxone is supposedly inert when you take the medication appropriately, but that if you were to try to not use buprenorphine appropriately, if you were to try to illicitly use it or inject it or something, that the naloxone would keep you from being able to get high. I'll be honest with you, the short version of this is it doesn't matter. Plain bup, combo bup, I don't care. It all works really well. Some patients don't tolerate the combo pill very well. It gives them GI upset. So if they want the plain one, just give them the plain one. They're both really safe and really effective. We like buprenorphine because unlike methadone or fentanyl or morphine or whatever, it's a partial agonist, meaning instead of turning that opioid receptor all the way on, you're only turning it part of the way on, enough to keep you from withdrawing and feeling terrible, to get that opioid in your system since you're dependent on it, but not to get high. And because of that, it also carries with it a ceiling effect for respiratory depression. You can't really overdose on buprenorphine alone. There is no upper limit to the dosing. You can go very, 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 very high, but those high doses are not going to cause overdose by themselves. Sure, in combination with other things that can make you stop breathing, like if you did, buprenorphine and some fentanyl and some alcohol, could you overdose? Yeah, of course you can. But bup by itself is a very safe medication. It has a really high affinity for the receptor. It will block other opioids. So if you have bup in your system and you use fentanyl, the fentanyl will not get onto that new receptor that the bup is on. The bup will hold on tighter. That's one reason you have to be in withdrawal before you can start taking bup. Because if you're high on like fentanyl and you give bup, it's going to knock that fentanyl off and bring you down. That's called precipitated withdrawal. It's not dangerous, but it feels pretty terrible, and we don't like that. So we wait for the patient to already be in withdrawal, and we bring them back up to normal by giving buprenorphine. It has a very long half-life. Most patients take it about once a day to stay in on MAT. And it kicks in within about 15 to 20 minutes, reaching peak effects at somewhere around 1 hour. When we look at methadone compared to buprenorphine, this is kind of a summary slide of all those differences, but the main benefits of bup, again, are that you don't have to go to an OTP. You can have a take-home prescription. It doesn't cause respiratory depression. It doesn't cause altered mental status. You can drive a car. And both of them, I want to point out, are safe in pregnancy and breastfeeding. Really important point. So the American College of Obstetrics and Gynecology also supports the use of MAT in pregnant and breastfeeding women. Certainly better for mom and baby than illicit drugs are. A couple of other FAQs. Patients do not have to start bup in the hospital. It is so safe that if they're not in withdrawal right now, they can do a take-home self-start prescription for when they are in withdrawal at home. Super safe med, does not require admission, even for pregnant patients. It is safe in minors. It is approved for 17 and up. It's been used off-label from 12 to 17 years old as well. Continues to be proven safe and effective, but we do get into some consent issues there. We won't deep dive into that right now, but generally, yes, it is safe and effective. Should I be worried about diversion? Short version? Not really, because it's cheaper than buprenorphine on the street? Fentanyl. It's easier to find? Fentanyl. It makes you feel really high? Fentanyl, exactly. And so bup is none of those things. We know that when patients are buying buprenorphine on the street, they're often trying to self-treat withdrawal, to do something, to go to a graduation, to, take a flight somewhere, to go to a job interview. They're trying to self-treat. So the best way to prevent diversion is to make bup easy to find for people who need it to be in treatment. It's not the same as like methadone or other full agonists being diverted. I wouldn't let that be a fear of yours. The DEA is not raiding anybody's offices for starting too many patients on medication for addiction treatment. They're very supportive of us doing this work. If somebody already on buprenorphine is in pain, a really key thing to know, do not stop the bup. Leave it in their system. You can go up on those doses to help with pain management. You can add on top of it meds like fentanyl or hydromorphone or whatever. You can add meds on top, but we want to leave bup in their system. It's really important to help treat their pain. And then when should somebody come off of buprenorphine? Well, I'm glad that you asked, because the short version is probably never. When we look at what happens if you take people off of bup, very obviously, I think this wouldn't surprise anybody that the more you taper their dose, the more likely they are to return to illicit use because their body still has dependence on opioid, right? To feel normal, they need their medication. This is like saying, when does a patient with diabetes come off of insulin? Sometimes they will, but most of the time they don't. They need insulin for forever because the physiologic changes in their body require exogenous insulin, medical insulin to stay normal. Same is true for patients who have opioid dependence. They will require that baseline opioid in their system to feel normal. And in fact, coming off of buprenorphine is dangerous because you return to illicit use and you have a higher risk of overdose in that setting. So we don't want to worry about taking patients off of MAT. For now, we start them on it, get them in treatment, and then certain patients can navigate with their clinician whether or not they want to come off in the long term. But MAT is sobriety. They are sober by being on their medication. That's a really important point. In addition to how important and awesome medications are, I do want to give a quick nod to something else, which is harm reduction. And when I say harm reduction, what I also really mean is living well. Because whether we like it or not, drugs are here to stay. And just like diabetic patients are going to, eat pizza and have donuts, and hypertensive patients are going to eat potato chips and not exercise, patients are going to use drugs. And so our job is to educate our patients so that they can be safe in making the decisions that they're going to make to help not ruin or even end their life in the process. Harm reduction really has two branches. That first branch has to do with reducing stigma. This is the moment for all of us to acknowledge that we have our own relationship to drugs. Whatever your personal and political and maybe religious feelings or thoughts are about drug use, we do all have one thing in common, which is that we got into this work because we care for people and we want to help people feel better. And so we have to first acknowledge that people are people first, and they're not defined by their behavioral choices or their diagnoses. And one way you can do that, I can do that, we all can do that, is by focusing on what's called person-first language. We don't want to refer to our patients as the derogatory labels we have given them for so many years. Tweaker, junkie, meth head, whatever. All that is so inappropriate and rude and degrading, and not the way we should talk about our patients. Instead, it's a person who has opioid use disorder, or a person who is using fentanyl, a person who has attempted suicide in the past, not a schizo, not a druggie. We just have to really start thinking about people as people. And I promise you that using those words help the patient realize that you care about them, and it'll help you in your own heart remember what you're here to do, that you're really just trying to help somebody. A couple of other tips for talking to patients and trying to reduce stigma and deal with the long history of stigma we have brought to these circumstances with these patients would be first to normalize. Make sure the patient knows you're not singling them out. Hey, a lot of my patients use fentanyl. Do you happen to use fentanyl? Right now, I'm not saying you look like somebody who uses fentanyl. I'm saying this is common. Let's talk about it. Acknowledge the past. Look, I know it's not easy to talk about this stuff with the doctor. We're not always very nice to patients who use drugs. And I'm really sorry if you've had bad experiences in the past. But today, here's the part where you align. My goal is to make you feel better. You look like you feel miserable, and I hate that for you. I want you to feel better. Can I ask you some questions? Can we try this medication? Always ask instead of assume. And remember that not everybody is going to be ready for treatment today. So how can we help this patient live well, or think about how to live well, even if they don't want the end outcome that you want, which is no more drugs and be on MAT? But we got to help our patients get there. A couple tools they can use. There are fentanyl test strips out there to try to find clandestine or hidden fentanyl in other drugs. What I will tell you is these products are getting a lot better over time, but they're still technically kind of hard to use. So I don't think that they're accessible to most patients. It requires a pretty decent health literacy level. There is some technique to it. They're not going to be perfect for everyone. They can only test drugs that have been dissolved. So pills have not been tested. Only dissolved powder can be tested. So it's just kind of a lot of work, but they are a good tool, and they are getting increasingly better over time. A way more accessible and awesome tool is going to be naloxone. To me, naloxone is the AED or the CPR of our generation. And I wish that naloxone was in the hands of every single person in America, but certainly every person who uses drugs or who knows somebody who uses drugs, because the illicit drug supply is not regulated. So you just don't know what's in it. You never know when fentanyl is going to be in somebody's drug. And frankly, the answer is these days, it always is. And so you want to be able to save somebody's life or have them be able to save their friend's life in the incident that there is an opioid, a clandestine opioid, or a somnolent kind of medication in that drug that they're using. We do have now some over-the-counter options for naloxone, and of course, you can always prescribe naloxone. The reality is that going to the pharmacy to get naloxone is not a popular choice. There is cost and stigma associated with that visit, and we know that only 1 or 2% of prescriptions for naloxone even get filled. The better option is to put it in people's hands. So if you don't know the details of a naloxone distribution program and wherever you're at watching this video, look into it, because there are a lot of options, especially in California. The state DHCS runs a free naloxone distribution program that you can participate in. If a patient is going to use a loan, sometimes our unhoused patients or patients who maybe, don't have friends and family, or certainly during COVID-19, a lot of people were at home using a loan. There's an amazing hotline I love telling people about called the Never Use a Loan hotline. And the way that it works is that you call, it's anonymous. You say your name and where you're at and what kind of drugs you're going to do. And they stay on the phone with you to make sure you don't overdose. And if you become unresponsive, they send EMS to you. So really amazing resource, completely free and anonymous, and anybody can use it. Everybody's got a phone, I feel like. So it's really helpful. And then finally, and this one might be a little bit more uncomfortable for certain people, but knowing how to talk to patients about using drugs. Can you, make choices that will help decrease the risks associated? Could you smoke it instead of injecting it, so you're not at risk of infection and, hepatitis and all that kind of stuff? Do you know how to use alcohol swabs and a tourniquet and not miss the vein? And do you know how to access sterile syringes? And, do you know all that kind of stuff and how to get screened for hepatitis C and HIV? If you're not comfortable talking about all of this, that's okay. There's a website, the National Harm Reduction Coalition, and they have patient-facing materials that talks about all of this with them. So you could even do something as simple as say, hey, I wish you didn't do drugs, but if you're going to, I really don't want you to die or get super sick from them. So let me show you this website. I want you to look at some of their stuff to make sure that you're being as safe as you can. And that's it. You could save a life that way. As a quick recap, opioids are killing way too many people. And we know that addiction is a chronic, treatable medical disease, and MAT is evidence-based and saves lives. So we have to make a medication-first approach with low barrier access a huge priority in all of our work in acute care. Both buprenorphine and methadone are really effective forms of MOUD. They absolutely save lives. But buprenorphine is preferred for us in the acute care setting, just for a couple of ease of use and practical reasons. Finally, harm reduction, getting rid of stigma, helping our patients live well has to be a part of the complete puzzle for us. This model, doing low barrier access MAT and counseling patients on harm reduction, as well as dropping our stigma, this is the new standard of care. This is evidence-based, it is person-centered, and I don't think I have enough words to express to you how excited I am to have you taking on this work and joining us. And I just want to thank you in advance for all of the work that you will do to help our patients live well.
Thank you, Dr. Gonzalez. That was super helpful and very informative. Now we're going to talk about the role of EMTs in patients with an opiate use disorder. What is the EMT role? So we're going to talk a little bit about how you can help people in crisis and how buprenorphine may play a role and how you can advocate for those patients. Now, medication-assisted treatment in EMS is a relatively new field. It was started in New Jersey, and our program in California was the second place in the country to do 911-based buprenorphine. This was one of the first papers out of Camden, New Jersey. And then we took that program and actually increased the availability of buprenorphine into California. And now it's going all over the country. And that's very, very exciting. But the whole idea is we evaluate patients who might be in opioid use withdrawal. Paramedics might give buprenorphine, but even if a paramedic isn't on scene, you as EMTs might be able to help these patients by assessing them, doing COW scores, and helping in other ways. maybe taking them to a facility that is ready to treat them and engage them in a clinic system. We also know that patients who do not get transported after an overdose have a higher risk of subsequent overdose and death. And it's a really important thing for us to remember. So remember also too that we are living in sort of the worst case scenario. We've had a lot of sustained exposure to opioids in the US population. And then we had this abrupt regulation and restriction, which without treatment, which led to more patients using, and fentanyl filled that vacuum. Now, EMT interventions are actually very interesting because there's a lot that EMTs can do, even if they can't administer buprenorphine. EMTs can screen for substance use disorder and opioid withdrawal. They can actually calculate an opioid withdrawal score, and we're going to talk about that in a minute. You can discuss with a patient's care and treatment for substance use disorders. You might be able to distribute naloxone kits. You can practice a particular type of interviewing with a patient called motivational interviewing during your assessment. You could transport them to a specialty center like a bridge hospital, which might have personnel there and willing and able to take care of these patients, as well as get them hooked into a clinic system. And then you can advocate for the patients once you're in the emergency department. So telling the nurses and the other clinicians that this patient is in opioid withdrawal and might benefit from buprenorphine. The first thing you can do is you can screen for opioid withdrawal. There are objective signs and subjective signs. The objective signs, being objective, you can actually measure. Is the patient tachycardic? Do they have sweaty skin, or are they diaphoretic? Are they restless? Are they agitated? Are their pupils dilated? Do they have like tearing, or are they having a runny nose? Do they have vomiting or diarrhea? Are they yawning, or do they have goose flesh skin? Those are all what we call objective signs, and they're pretty helpful for determining if a patient has opioid withdrawal. There are also some subjective signs, which are, as the word would imply, subjective, that may be a little bit looser to interpretation and maybe less specific. So nausea or cramps or body aches or achy bones or joints, or restlessness, or are they hot and cold, or nasal congestion. You're relying upon the patient experience and explanation for those signs. What those all do are to help you calculate what's called a clinical opioid withdrawal score. And this scoring system has been developed to help assess how much withdrawal the patient is in. We consider a COWS score of 7 or above significant, moderate to severe opioid withdrawal. And these patients might be eligible for buprenorphine in the emergency department, or if a paramedic rig was enabled with buprenorphine, might be possible to get buprenorphine in the field. This is important for you to share with a receiving clinician that the patient's COWS score is elevated. This is actually super important and might help them get access to other medications like buprenorphine. Now, there are a couple medications that we oftentimes talk about for patients who are experiencing opioid use disorder. There are a couple things. First, we've all heard of methadone. Methadone is an oral solution, which is a full, what we call agonist to the opioid receptor. It turns on all of the receptors all at once. The problem with methadone is that only certain clinics can give it out. It also, patients can technically overdose on it. And it's a little bit harder to access and be maintained on methadone. Buprenorphine is a really interesting drug, which you may have heard about before, but because it's a partial agonist, it doesn't have a lot of the dangerous side effects that a full agonist would have. It tends to not make the patient sedated. It tends to not stop their breathing. And there's a ceiling effect in it. So the receptors are only turned on about 50%, which means that they are treated for their opioid withdrawal symptoms, but they don't become sedated or stop breathing. And that's really important. We don't really use naltrexone very much in the emergency department, although a lot of long-term outpatient opioid dependency clinics might. But we really focus in the emergency department and in EMS on buprenorphine. There are some formulations of buprenorphine that have naloxone in them. And that's typically what we use, these films, these sublingual films that the patient puts under their tongue and absorbs them. the naloxone isn't as important as the buprenorphine itself. It was put in the buprenorphine formulation to decrease the possibility that the patient might use it inappropriately. But we're just focusing on the buprenorphine, and that is what we're using in EMS. Another thing that EMTs can do is actually do public distribution of Narcan kits. There are a lot of state programs which offer naloxone kits to the public, and EMS agencies, libraries, community centers, other sort of community organizations oftentimes distribute these naloxone kits. A lot of EMTs are equipped with these kits, and they should be distributed to community members, patients, family members, and anyone else who might be at risk. And that is a way to do harm reduction and to help prevent death. We now have, we're hitting over 120,000 people in the US who have died from an opioid overdose in the last year. One of the other things that EMTs can do is they can use more motivational interviewing during the patient assessment. You'll hear more about this from Vanessa Lara, but it's important to talk about in terms of you partnering with the patients. It's very goal-directed and it's patient-focused, and patients really respond to this type of interviewing. And it's different than our traditional sort of medical model of sort of, I'll ask the questions, you answer. It's more about partnering with the patients and getting them to be on board with engaging with help. And it's a really interesting and important way to engage with patients. Another thing you can do as EMTs is you can transport them to a bridge hospital. We sometimes would call them an overdose receiving center, like a trauma center or a STEMI center or a stroke center. The idea would be that, like, we have specialized personnel there, maybe the medications, and get them into clinics. We now just call them bridge sites, and there's many more of them around California. There's over 200, and it's a model that is being adopted throughout the country now. But the idea would be that the clinical champion starts treatment in the emergency department and then connects the patients to a navigator. And that navigator can provide education, support, linkage to a clinic, maybe get them appointments in the next couple of days to get them follow-up and to help them get long-term engagement. And then the patient actually gets like care that is evidence-based, that has been shown to decrease mortality. Just so you know, if a patient is engaged in long-term treatment, they have a 70% reduction in mortality from overdose. That is amazing. And there's almost nothing we do in medicine, not heart attack care, not stroke care, which reduces mortality by 70%. It's insane how effective this long-term medication-assisted treatment is in terms of helping these patients. If you need to identify which is a bridge hospital, there's a downloadable list. You can pull out your phone and do this QR code to see which are the bridge hospitals. And these are hospitals which have had funding from the state to hire substance use navigators. Oftentimes your EMS agency might provide you with these designated receiving sites as well. And one of the final things you can do is you can have a warm handoff to ED clinicians. And this is the idea of, once you are at the emergency department, you tell the triage nurse, you tell the doc, whoever is receiving these patients, that you are advocating for the patient, that you've done a COWS score, the patient is in opioid withdrawal, and they might benefit from buprenorphine. Sometimes clinicians may not have a lot of experience using it, and you even saying it might jog their memory to say, oh, right, I've heard about that, or I've used it only a couple of times. You're right, this would be a great patient to start on buprenorphine. So your advocacy can really help these patients. And even as an EMT, it's important to remember that these patients deserve the best possible care you can provide. And being their advocate is a role that is incredibly important that you can help with. You can also help them to partner and link with a substance use navigator. Maybe there are signs in the ED about how to reach them. And you can advocate for them that way. Excellent. So now we are going to hear from Vanessa Lara. She's an amazing leader in this field, and she is going to talk on motivational interviewing and how it can be effective.
Thank you, Gene. That was amazing. Thank you all for joining us. My name is Vanessa Lara, and I'm the project manager for EMS Bridge. Today, I'll be walking you through the motivational interviewing for EMS patients. My goal is to help you understand the fundamentals and apply the techniques to each stage of behavior change. Motivational interviewing is a counseling technique that uses a particular style of conversation to talk about change. It ensures that a person's own experience and feelings are considered when seeking to resolve ambivalence during a conversation about change. Motivational interviewing is always directive, patient-centered, focused, and goal-oriented. The style and spirit of motivational interviewing refer to the manner in which the clinician interacts with their patient. The spirit of motivational interviewing encompasses the underlying philosophy and intention behind the clinician's approach. It involves a genuine belief in the client's autonomy, intrinsic motivation, and capacity for change. The spirit of motivational interviewing is characterized by partnership, acceptance, compassion, and evocation. It recognizes that the patient is the expert in their own life and acknowledges the importance of honoring their autonomy and self-determination. Motivational interviewing is a collaborative process. You'll work together with mutual respect and support. As a clinician, it's important to remember to allow space for the patient to voice their own perspective, values, goals, and concerns. As an expert in change, you will approach the conversation with an individual using a lens of curiosity to understand the patient's own experience and feelings about a situation. Showing up for your patients with acceptance means demonstrating positive regard without judgment or criticism. As a clinician, it is your goal and privilege to help others. To successfully use motivational interviewing, you should approach the patient with empathy, compassion, and an understanding that during the conversation, you should recognize the client's struggles, ambivalence, and the challenges they may face in making behavior changes. Compassion helps create a non-threatening and supportive environment for your patient. A clinician should help the patient bring forth the patient's intrinsic motivation to elicit their own reasons and desire for change. Help the patient explore and articulate their own personal motivation and goals, rather than imposing external motivation or judgment. By embodying the style and spirit of motivational interviewing, you can foster a therapeutic relationship that encourages self-reflection, supports intrinsic motivation, and facilitates a positive change. A key component to motivational interviewing is remaining non-judgmental. Interestingly enough, a lot of communication is nonverbal. So consider your body language, your tone of voice when you're having these conversations with your patient. Small changes are really the building blocks of larger behavior change. It's unrealistic to expect an 180-degree turnarounds or complete abstinence at the start of any journey. Instead, implementing smaller changes like reducing the amount used, use of sterile equipment, or carrying naloxone will have a greater impact overall. While these options may not be abstinence-based, they're all harm reduction focused and can lead to future behavior change. This is a scale that depicts where people might fall when they are considering any change in their life. When approaching the conversation about substance use or treatment, make the assumption that every person is ambivalent about change. If the patient indicates they are ready for change, a good resource to use is an action plan. Now, action plans don't have to be fully involved. Working through one step that a patient can take today is enough. If a patient is unsure if they'd like to engage in treatment, use open-ended questions to further explore their feelings. Resistance will happen, and that's okay. By addressing resistance with respect, empathy, and understanding, you may help resolve some of that ambivalence and increase their readiness for change. Now, you've likely already seen these stages of behavior change. But behavior change is rarely a discrete single event. For most people, behavior change occurs gradually over time, with the person progressing from being uninterested, pre-contemplation, they're unaware or unwilling to make a change at this time, to possibly considering change, contemplation, then moving towards deciding and preparing to make a change, preparation, to then following a definitive action plan, and finally making attempts to maintain the new behavior over time, maintenance. And people can progress in both directions in the stages of change. Most people will recycle or relapse through any of these stages of change before the change becomes fully established. Now let's walk through each stage of behavior change a bit more in depth. During the pre-contemplation phase, individuals may still not be aware or not considering making any changes. As the clinicians, this is a time to explore the patient's perception of their health by asking questions. In the contemplation phase, people are starting to question and more closely examine something in their life that they might want to change. Although they may recognize some negative feelings toward a certain behavior, people often feel ambivalent about change in this stage. At this time, you can explore pros and cons with them, highlight people in their life who may be a support system for them. Preparation. During the preparation stage, a person has made the decision to change this time, and this time is often filled with research on change, gathering information, seeking support, or setting specific goals to facilitate the behavior change. As the clinician, this is an opportunity to recognize the challenges and help problem solve and provide positive affirmations. The action stage. The patient is actively modifying behaviors, implementing plan changes, and adopting new habits or practices. Individuals in this stage are engaged, but still require support to maintain their commitment to change. This is a great time to ask a patient about their decision to change and acknowledging any changes that they feel good about. Maintenance. When people have successfully made a change, they enter the maintenance phase. During the stage, they work to sustain the new behavior and prevent relapse. The stage requires ongoing effort, coping strategies, and support to consolidate the behavior change as a long-term habit. Let's discuss change talk. This is any content shared by an individual that leans towards a positive change. The examples on the screen show 4 types of change talk: desire, ability, reason, and need. Keep an ear open for any similar phrases because change talk is a strong predictor of future behavior change. And this can be leveraged to help explore someone's motivation to change. OARS. OARS is an acronym that represents the core communication skills used in motivational interviewing. It stands for open-ended questions, affirmations, reflections, and summary. Open-ended questions are a foundational technique that's often used in de-escalation. They stimulate thought in the patient and allow for exploration of the patient's ideas, feelings, and motivations. Open-ended questions typically begin with what, how, or tell me about. On the left-hand side are examples of closed-ended questions. Closed-ended questions only allow for an individual to answer yes or no. So instead of, do you use heroin? Are you withdrawing? Don't you want to stop? Consider these. What do you use? How are you feeling? Tell me about your feelings about quitting. Affirmations. Affirmations refer to statements made by the practitioner to the patient, acknowledging patient's strengths and wins regardless of the size. Focusing on positive affirmations reinforces the patient's motivation for change. Consider some of these examples of affirmations. I appreciate your honesty. I recognize your commitment. This is hard work you're doing. Reflections involve actively listening to your patient and, like a mirror, reflecting back what they have said. This demonstrates empathy, understanding, and validates a person's experience. An example of this sounds like, patient, it has been challenging to stay sober because of my stressful job, and this is upsetting me. Clinician, I hear that you're finding it challenging to stay sober because of your stressful job, and this is making you upset. Consider some of these reflections. Summaries. Summaries are succinct recaps of larger amounts of information that contain important points made during your conversation. Summaries are useful for highlighting any key information and ultimately closing the loop on that conversation. And lastly, don't forget what really matters. Compassion, empathy, and a non-judgmental approach are the foundations of motivational interviewing and are critical to building a connection to your patients. It's important to recognize that many in this patient population have a distrust of providers due to negative experiences and patient stigmatization. But using the techniques you learned here today will help soften those relationships and build trust. Remember to focus on change talk, listen with curiosity, provide positive affirmations, and lastly, roll with resistance. Now I'm going to pass it back over to Dr. Hern.
Thank you, Vanessa. That was super helpful and really interesting. Now we're going to talk about bringing it all together. We're going to talk about some case studies that will help you understand a little bit more about the use of a COW score and which patients may or may not benefit from buprenorphine, and again, how you can help as an EMT. So here's the first scenario. EMS is dispatched for some GI distress, nausea and vomiting. Upon arrival, the patient is a 38-year-old female complaining of abdominal pain and vomiting. The patient's alert and oriented and has no other complaints of injuries. They have been on OxyContin and they take 120 milligrams a day, but they haven't refilled their prescription and they've been out of their medication for 2 days. The patient appears restless, they're unable to sit still, and they periodically sort of wipe beads of sweat off their forehead. Their vitals are as follows: pulse of 110, blood pressure 136/80, temperature's normal, breathing at 20. Their skin is diaphoretic, pink, with less than 2-second cap refill, and their pupils are moderately dilated. Now stop here for a second, pull out your COW score, and calculate what you think their COW's score is. I'll wait a few seconds. Okay, their COW's is 15. The patient is an appropriate candidate for buprenorphine, so you can advocate for them in the emergency department. Or if maybe a paramedic supervisor is available and they have buprenorphine, that may be another reasonable option. Provide some resources and encourage them to get transported to a bridge site, and that's how you can help, and then advocate for them as a patient advocate in the emergency department to the emergency department personnel. Okay, next scenario. EMS is dispatched for a possible overdose. Upon arrival, the patient is sitting on a curb with some friends who report to have administered 4 milligrams of naloxone after finding him unresponsive. The patient reports he snorted a white powder that he thought was cocaine. For the patient, he occasionally uses cocaine and has no history of an opioid use disorder or regular opioid use. The patient is alert and oriented and has no other complaints. His vitals are as follows: blood pressure is 106/80, pulse is 82, temperature is 97.5, his respiratory rate is 16, his skin is pink and normal, and his pupils are normal as well. So first of all, he doesn't have an opioid use disorder, but let's go ahead and calculate the COW score anyway. His COW score is only 1. So not only is he not a candidate because he doesn't have a opioid use disorder, he's also not a candidate because his COW score is too low. He's not in withdrawal because he is not a regular user of an opioid. He thought he was doing something else. So this is an unintended use of a narcotic. So he's not an appropriate candidate for buprenorphine. That being said, he may have other substance use issues that we might want to address. So it's reasonable to transport him to a bridge site, get him hooked on with a substance use navigator who can help him with perhaps his other issues as well. So in closing, I want you to be aware that there are a ton of resources for everything we talked about today and so much more. Please visit our website, pull out your phone, look at the QR code. Patients, EMS physician resources are all at bridgetotreatment.org. If you have any other questions, please contact us at EMS Bridge at bridgetotreatment.org or our dedicated EMS Bridge website, www.emsbridge.org. Thank you so much. I want to really thank Dr. Gonzalez as well as Vanessa Lara, who have been tremendous helps for this program. And we look forward to hearing back from you about any other questions you might have and about the successes that you have achieved and have reached implementing these protocols. Thank you so much for joining us.